So initially, you should know very little physiology to understand pharmacology. So the cardiac conduction pathways and action potentials, as all of you know, the excitability starts at SA node, then it comes to AV node, bundle of his and Purkinje fibers, and then it waves off. And the action potentials are in the SA node and AV node, atria and AV node, calcium predominates. Calcium predominates and they are slow. Whereas in ventricles, it is fast channels and sodium predominates. And here, though there are the same phase 0 to phase 4, here it is quite prominent, whereas here it is merged because very little sodium is encountered here, more of calcium is there. This will repercuss us on the treatment aspect also. So you have to know about this, why these are fast channels and why this is slow channel, and also calcium predominates here. Okay. Now, fast versus slow response tissues. You know that fast response tissues are in atria, specialized infranodal conductive system, ventricles, and AV bypass, whereas slow response are mainly in SA node, AV node, and phase 0. Upon the calcium, in which phase 0 depends upon the calcium current, especially in SA node and AV node. And you can see the voltage dependent in the normal resting. In the past, it is about -80 to 95, whereas here it is little low. Here mainly it is sodium in fast, whereas primarily calcium. And here again the phase 0 channel kinetics is very fast, and here it is slow. And inactivated, because of inactivation depends on the voltage and cell calcium contraction. Inactivated state of the calcium channels. And the action potential amplitude is also very high here, whereas it is very smooth like a parabola. The threshold voltage again is quite high here compared to AV node and SA node or atria. The conduction velocity is very, very fast here, and it can lead on to ventricular fibrillation totally immediately. Whereas this is comparatively, compared to this, it is slow, not that per se it is slow. Conductivity to re-entry only with inactivation of sodium channels with marked slowing of the conduction velocity, whereas it is present in the normal tissues as such slow response. Automaticity is present in both the tissues. These are the major electrophysiological changes that we see. So action potential of slow response tissue, as I told you, it starts here in the SA node and AV node at -60. Then it comes to peak where calcium channels close. It would have got opened at 40. Then it closes where potassium channels open. So repolarization takes place. Then decreased calcium permeability and increased potassium. So that repolarization takes place. Then there is a slow depolarization of the pacemaker potential where the action potential is seen. So it is mainly in the cells of SA node and AV node where we say as pacemaker of action potential is seen. The ECG findings are similar to that. We see mainly in the ventricles because they are very, very fast channels. P denotes the atria, QRS the ventricles, and T almost the phase 3 repolarization, and phase 4 you have it is going to start one more action potential here in the U. The ECG findings are these. I think you people know better. P is mainly atria, 160 millimeters, and QT interval is 360 milliseconds. QRS complex is only 100 milliseconds, where the ventricles have to fill completely. And from R to R, we calculate the heart rate depending on these squares. So, cardiac arrhythmias can be disorders of rate, rhythm, origin, or conduction of impulses with the heart. We are more bothered about the rate, and we try to bring down the rate as much as possible. Rhythm sometimes, but it is quite difficult to see this one. So, in the sinus node, there is always sinus arrhythmias, atrial arrhythmias, nodal arrhythmias. All three put together are known as supraventricular, above ventricle, so supraventricular arrhythmias. And in ventricles, it is mainly ventricular arrhythmias. These are all small tips what you have to remember, though you know better, and repeated things will make you remember very nicely than undergoing amnesia. The mechanism of arrhythmias are mainly two types, or it can be both put together, but mainly of impulse generation there is changed abnormal automaticity, or there is triggered rhythms where there is early and delayed after depolarization, and abnormal impulse conduction where we normally see re-entry circus movement. So these are the mechanisms of arrhythmias. We see here. See here, we are seeing partial depolarization of resting membrane potential due to extracellular potassium. Okay. Then we see reduced outward current. Then increased inward current. Inward current is calcium, L-type channels. And here outward is potassium. Always inside the cell, sodium and calcium. Outside is potassium. Only when potassium goes outside, the cell can contract normally. And it is exacerbated by bradycardia. I hope you are understanding this. Okay, so here what has happened? See, initially what has happened here? Partial depolarization of resting membrane potential due to increased extracellular potassium. So it is going immediately. Immediately it is going. You see this, there is no complete action potential. It is going like this. Whereas here, you are seeing reduced outward current, so that in potassium is reducing, increased inward current, calcium is increasing. So you see at the end of phase 2 or beginning of phase 3 itself, you are getting one more depolarization known as early after depolarization. This is the whole action potential. Phase 0, 1, 2, 3, 4. Again, it is starting a new action potential. So here it is short. The duration here, the between action potentials, it is short, but here it is long. So then only you see all these types of arrhythmias. So if at all, if it does not come to phase 4 and then before that only if it proceeds, it is known as early after depolarization. Most of the times it is either MI or any structural heart disease, potassium and bradycardia. Whereas here we see increased intracellular calcium. Most often increased intracellular calcium, as I told you in the last class, is mainly because of digoxin toxicity. So digoxin has got a narrow margin of safety. It has got a very narrow margin of safety, and so we have to measure the concentration. So what happens, because of increased intracellular calcium, there can be arrhythmias, and it is also known to produce. It is also known to be used in atrial arrhythmias because of its vagolytic effect. Because of its vagolytic effect, it is exacerbated by catecholamines because of increased heart rate, and also polymorphic ventricular tachycardia is seen in these cases. So the second variety is re-entry. Normally what happens, the impulses comes like this, then they get, they wave off in a normal action potential so that it goes and gets discharged. Okay, so but what happens in a unidirectional block, instead of spreading directly, it goes again back and then it spreads here, so that the re-entry is again here, which can cause arrhythmias. So most common reason for VA in the presence of structural heart disease, which can be anatomical or functional, and this in the atrioventricular node, there is an atrial impulse typically discharged by an ectopic focus. Ectopic focus means other than SA node, AV node, bundle of his and Purkinje fibers, there is another focus that is known as ectopic focus, which reaches the AV node. Then the impulse circulates back through the atrioventricular node and establishes a re-entry circuit. This is what is shown here. And the impulse will spread through the atria regularly and activate instead of going to ventricles. Next, what happens? This is the ultimate what can happen. So ventricles are depolarized normally through his Purkinje fibers, which cannot be. The two pathways with the atrioventricular node, one is refractory, the other is not. Impulse is blocked in the refractory pathway but conducted through the excitable pathway. So here, see here it is going like this, but here it is blocked completely so that it can regenerate further. So this classification of antiarrhythmics was first done by Singh-Wang classification, which is followed today, and new drugs have led to an update of the system. The Oxford classification of updated on 2018. So class 1 agents are further divided into 1A, 1B, 1C, which are mainly sodium channel blockers. That means the phase 1, phase 0 is altered. Phase 2 is beta blockers, as we have been repeatedly telling. By this time you must have mugged up also. There is a conduction because of beta receptor blockade. That is GPCR activity, decreased CAMP, and so decreased calcium in the cytoplasm as well as sarcoplasmic reticulum, thereby decreased stimulation of myosin light chain kinase. So these are the sequences which can occur, and so beta blockers can be used as antiarrhythmics because of decrease in conduction. So they are claimed to be class 2 drugs. Class 3 are mainly potassium channel blockers, but they have got a altogether a total 4 types of mechanism of action. So they are known as broad spectrum antiarrhythmic drugs. So you should know about 10 drugs which are broad spectrum in pharmacology. So this is one of the questions which is given either in Viva or in CET and other things. About 10 drugs are there which are broad spectrum drugs in pharmacology. One of them is class 3 amiodarone, which is mainly a potassium channel blocker. But in addition, it has also got all the actions of 1, 2, and 4. Next, fourth is calcium channel blockers, L-type calcium channels in the cardiomyocytes, which has a good effect on the heart. If it is L-type calcium channels on the blood vessels, then we have used it in hypertension and angina, whereas this has got an action on the heart, especially on the conducting system, so that the conduction is slowed down and hence bradycardia can be seen. But if it is severe, we have to urgently stop these drugs. The class 4 is miscellaneous as well as the newer drugs. This is the revised Wagon-Williams classification, which was done in 2018. It is the same, little bit of differences there in their actions. So, class 0, it is HCN calcium channel blockers, ivabradine, which we are using very now. Where do we use it? Any idea? Anybody has joined? Ivabradine is a drug which acts on funny channel currents, and this is used when beta blockers does not decrease the heart rate below 100 or 90. Only then you add ivabradine. Otherwise, most often we try to keep it as such as a reserve drug. Now, this in 2018 we have classified further 1A to D, which are sodium channel blockers. In second one, A to E, which are autonomic inhibitors and activators. Class 3, 3A, 3B, which are potassium channel openers and blockers. Fourth is calcium modulators. Fifth is mechanoselective calcium channel blockers. Sixth is gap junction calcium channel gap junction channel blockers. And seventh is upstream targeted modulators, like which can block even the metabolic pathway so that they decrease in rate as well as rhythm. Now, the mechanism, the usual 4 drugs which I have got, the mechanism of action, as I told you, class 1, they mainly block the phase 0, that is the sodium inward current is blocked. Once the sodium inward current is blocked, the height is decreased and it is slowed. Once it is slowed, I think all of you know this, no? Phase 0 is sodium, potassium is, phase 1 is potassium and calcium is out, chloride and potassium are out, sodium is slowly coming in, sodium and calcium. Calcium is inward for a long time, so plateau. Potassium in the third phase, which is going out of the tissues and hence it is undergoing repolarization. Here it is potassium rectifier current where it comes back to RMP and one more action potential starts here. So these are the ionic currents which you have to be familiar with so that we can know the particular actions of each drug and hence accordingly act. So here the class 1 are mainly sodium channel blockers. They differ in certain of the pharmacokinetic factors as well as adverse effects and drug interactions and also the route of administration. So we put it accordingly. Mainly they are sodium channel blockers. Mainly the inactivated state of the sodium channels are blocked here. So that this portion is known as the action potential duration. Until here, from here to till here it is known as effective refractory period where any amount of stimulus will not stimulate the further action potential. So this is the meaning of effective refractory period. Absolute refractory period is a whole thing where the action potential does not occur at all. If the total action potential duration is long, the effect is different, and if it is shortened, it can be a different action can be produced. And if ERP is prolonged, then the action potential can come back to normal, and so we can see the normal heart rate and other things. So class 2 is mainly beta blocker. Here mainly we use propranolol, metoprolol. And in class 3, it is potassium channel blocker, amiodarone, sotalol. Sotalol, though it is a class 2, it has got additional actions of potassium. So we classify under class 3. Calcium 4 is mainly calcium CCBs, that is non-DHPs, mainly verapamil. Diltiazem has got 50-50 chances both in blood vessels as well as heart. Now, we will just go through a case history and then come to the drug so that you can understand something. A 64-year-old man with sarcoidosis, left heart catheterization, VT, VFib, HF, cerebral aneurysm, PE, and CKD stage 3 presented to the emergency room after receiving 7 ICD shocks at home. He had multiple episodes of sustained monomorphic VT with ICD shocks that did not convert to normal sinus rhythm. So, VT storm is also there. Previously, he had been given amiodarone for VT, but had been stopped due to hyperthyroidism because one of the side effects, because it is an thyroxine analog, the thyroxine analog, we can see both hypothyroidism as well as hyperthyroidism with amiodarone, where we have to monitor it continuously. So normal sinus rhythm was restored with intravenous lidocaine and amiodarone bolus because lidocaine is a sodium channel blocker. Amiodarone is a broad spectrum antiarrhythmic. Laboratory studies were all within normal limits, and he was started lidocaine drip with 1 milligram per minute. Never lidocaine is given orally because of first pass metabolism, mainly through increased hepatic blood flow. And mexiletine is in one class 1C drug, which can be given orally for especially atrial arrhythmias, 200 milligrams orally every 8 hours. And infusion was weaned off on the hospital day 2 to bridge with mexiletine orally every 8 hours because the onset of action is very late. So till now, it is good. So on second day, he was observed to have intermittent confusion, waxing waning pattern, terminate the lidocaine infusion. Why? Because lidocaine has got CNS and CVS adverse effects. So here he has got CNS adverse effects. Then he had an episode of unresponsiveness with eyes open but inability to follow commands associated with drooling and shaking of jaw, which was a significant deviation from the basal status of full alertness and orientation. That is the lidocaine side effects. So then we saw that it is 130 to 140 beats per minute. He was evaluated neurologically, but patient and it was agreed that the patient was post-ictal secondary to what was most likely a seizure caused by lidocaine toxicity. That is once again CNS toxicity. No previous seizure history. Both lidocaine and mexiletine were stopped because they are known to produce seizures. And 4 milligrams of lorazepam was administered because this is the first choice in any case of seizures, especially in status epilepticus. Because of life-threatening nature of arrhythmia and seizures, amiodarone was started for 7 days, followed by 200, despite the previous thyroid effects, so that we can monitor further. On day 5, they was discharged with amiodarone 400 mg twice daily for 3 more days, followed by amiodarone 200 mg, metoprolol 550 mg twice daily, along with concomitant therapy for comorbid conditions. Why they have done both of them? Metoprolol decreases heart rate, that is a standard drug for atrial arrhythmias. Amiodarone, we have decreased the dose for the fear of side effects. So these are few of the drugs which are used in class 1, A, B, C, and also class 2 and class 3 drugs. So we will see what are the effects of these. In class 1 antiarrhythmics, they block, as I told you, they block phase 0. First point is they block phase 0. So once they block phase 0, what happens? Slow rate of depolarization prolongs ERP, effective refractory period, and also prolongs APD. That means no amount of stimulus can bring about one more action potential. Once the action potential is prolonged, all the ionic currents are delayed. Ionic currents inward and outward are delayed. And 1A, 1B drugs do have potassium blocking activity. That means cell is going to rest. 1C have got the slowest binding and dissociation from the binding site. So their duration of action is prolonged. And IB will rapidly bind and dissociate. So we are supposed to look at these actions. So we cannot give orally. We have to give multiple times. So they are reserved for parenteral route. And 1A has got intermediate action, which is shown in this diagram. So you can see this resting closed, outside potassium, inside outside sodium, inside potassium. Activated, sodium enters inside. Inactivated, close, sodium cannot enter inside because it is inactivated. And resting, close, again coming back to resting potential, same as this, where the sodium cannot entry, and so the the action potential has got repolarized, going back to the depolarization state. So these different states are important clinically, since class 1 antiarrhythmic drugs preferentially bind to open and inactivated. That means here open here. Okay, that is almost phase 0 and 1. They act on these areas, and they act on inactivated sodium channels. Inactivated sodium channels here. So these two are the areas where class 1 antiarrhythmic acts, and so you have to know this portion. This portion is almost completely acted on by class 1A, class 1 antiarrhythmic agents. So which are the drugs? In these, because they prolong both ERP and AP duration, we have got several drugs, but most of them are not used because of various side effects. And they are metabolites. And metabolites, if at all they have either toxicity or prolonged duration of action. So procydamide, we do not use. This is a congener of procaine, which is a local anesthetic, which can be hydrolyzed by esterases, and also it has got a metabolite. We have to have a loading dose also because of these, and notable side effects are also many. So we are reserving these drugs. Quinidine, mainly for synchronism, and drug interactions. We do not use because we have got better drugs nowadays. Diazopyramide can precipitate heart failure and also have antimuscarinic effects especially in adults. Adult males we cannot use because it can act, patients might have BPH, benign prostatic hypertrophy, or even glaucoma, where both of them can be worsened. So these are the adverse effects. So you should know the adverse effects and then start on the treatment. Lidocaine mainly used as a loading dose and maintaining this dose because the therapeutic index is very small, and it cannot be given orally because it is not at all absorbed and undergoes very high first pass metabolism. So for that reason, it is used only by IV and mainly in digoxin-induced ventricular arrhythmias, not in supraventricular, because it does not have any action on the calcium channels. In the atrial arrhythmias, it is mainly calcium which is involved. So we do not use it at all. It does not have any action on calcium. So we use it only in digoxin-induced ventricular arrhythmias. It acts on phase 1, that is sodium open, more than open. It is inactivated sodium channels where it acts mainly. There is both CNS toxicity as well as CVS toxicity. Mainly CVS, it is depressant, and CNS, there is a CNS toxicity till causing seizures also. So we have to be quite careful. And patient, if they are very alert, they can say this cardiac depressant activity that my heart is not thumping at all. So there was a patient where lignocaine was given for DNC. So lignocaine was given as a local block in the cervical block, and they started with DNC. But the patient who was educated, they said that I don't feel my heart sounds at all. Yeah, I'm feeling as though everything is nil. So these were the problems. So then, because the patient was educated, they knew the awareness was there. It was totally stopped and it was reverted. So we should know, if they're educated, you should have told all these things so that many of the toxicities can be overcome by these means. Mexiletine, we are further bothered about QT interval and also blurred vision. Vision is hampering. The same thing is there with amiodarone as well as ivabradine and other drugs in pharmacology. So you have to be very careful. So for that reason, we really see to it that mexiletine is used only in the ventricular arrhythmias as a last drug of choice, and off-label uses are diabetic neuropathy, where the patient will complain of tingling sensation. In such cases, we can use low dose of mexiletine here. In class 1C, normal AP duration is there, action potential duration, and normal ERP is there. So the problem mainly is exacerbation of arrhythmias itself. They are all pro-arrhythmic drugs. And so you have to be careful. You have to weigh out the risk-benefit ratio and see the renal and hepatic function, and then you have to see this. In the CAS study, we see that ventricular ectopy is overcome is the main side effect, and so this was terminated. And flecainide, we should really think of using it once or twice. So what are the caveats? The caveats with the class 1 drugs are they have got use dependent blockade. So once they are use dependent blockade, they can be used only during fast heart rates. There is less time for the drug to dissociate. So increased number of blocked sodium channels are there. Enhanced blockade, cardiac depressant activity. So widens the QRS. Once the cardiac depressant activity and widens QRS, there can be total block also. And seen with class 1C, where they are slow to bind and dissociate like lidocaine, and rarely with class 1B, so we can use it orally, and this contributes to pro-arrhythmic state. And they also have some of the reverse use dependence of class 1 drugs. At slow rates, there is potassium channel blockade becomes prominent, and once this potassium channel blockade becomes prominent, it causes QT prolongation and increases automaticity, and so hence again they are pro-arrhythmic in nature. So this is the algorithm, what we see how to use the sodium channel blockers in each patient after clinical findings mainly, and also ECG, which is a poor man's angiogram. How to use beta blockers. This is one of the case history where we can shift it to the how we can use it in these cases. A 25-year-old woman, LV dysfunction, pregnant, so pregnancy induced, then decompensated heart failure with various ventricular arrhythmias, hospitalization at 21st week. So furosemide was given and low dose sotalol were added for an ongoing treatment with carvedilol and spironolactone due to risk of hemodynamic collapse. Then emergency cesarean section was performed at the end of 32 weeks, and there was non-sustained ventricular tachycardia. Following delivery, sacubitril and valsartan was commenced. Why? Because of decompensated heart failure and say HF symptoms, heart failure symptoms, and carvedilol was increased to 6.25 instead of 3.125 because of heart failure. A low dose of sotalol was maintained for the suppression of paroxysmal ventricular contractions and VT, ventricular tachycardia, and this was sufficient to prevent sudden cardiac death. So always beta blockers are indicated to prevent certain sudden cardiac death, and also it is an anti-mortality agent. So looking into that, class 2 drugs, what do? They mainly decrease heart rate. Even in your dreams, these two should be there. Decreased heart rate, so decreased conduction velocity in the atria, and this DAD and EAD are less triggering factors in these cases, so less cardiovascular outcomes, membrane stabilizing effect because of sodium blocking activity, and hence there is increased action potential duration, increased ERP, and increased DOR also, so that there is decreased fibrosis, which contributes to its in heart failure, and hence decreased re-entry, which is a very, very good effect what we see. So mainly they inhibit sympathetic activity beta 1, reduced automaticity by slowing phase 4, spontaneous depolarization. So the cardiac action potential will come back to normal. The next, increases refractionaries in phase 2 and 3. So the action potential duration is prolonged, reduces speed of impulse propagation. So again, this is one of the contributory factors to the action potential duration. So hence, effective both in supraventricular. In supraventricular, decreases the heart rate, and in ventricular arrhythmias, it decreases the bombardment of the impulses from atria to ventricle, and also increases the APD, ERP, DOR, and hence decreases the fibrosis. So you can see that given IV for rapid control, esmolol is an ultra short acting drug. Ultra short acting drug, onset of action is within 30 seconds, and the duration of action is only about for 20 minutes. So you should name 10 ultra short acting drugs. In this chapter, you can see two things. One is ultra short acting drugs. The other one is broad spectrum drugs which are used in pharmacology. So esmolol is an IV for rapid control of ventricular rate in patients with flutter to fibrillation. It is hence an used as anti-atrial arrhythmias and WPW syndrome, and also in degenerative induced arrhythmias in ICUs. Whereas for oral, we commonly use propranolol, atenolol, metoprolol. In MI, to reduce the incidence of sudden death due to ventricular arrhythmias. So it reduces both atrial and ventricular anti-mortality and anti-arrhythmic. So hence we are using these drugs. The adverse effects are mainly cardiac and extracardiac because of the propagation of the impulses decrease sinus bradycardia, which can lead on to AV block. And when continuously given at higher doses and suddenly withdrawn, it can have withdrawal syndrome, which can also result in sudden cardiac death. The extra ones are mainly bronchospasm, which can lead to and hence contraindicated in COPD and asthma, fatigue, and hypoglycemic unawareness, especially in non-selective beta blockers, especially in some non-selective beta blockers like propranolol. So coming to the third, a 46-year-old male presents with ICD shocks with last 24 hours while consciousness and asymptomatic, and he has experienced hot flashes in past 2 months and has been on an amiodarone for recurrent VT for 5 years. Past history, chronic CHF, secondary to muscular dystrophy, primary prevention, subcutaneous ICD, LVEF is 10 to 15. So God only save the king. And last visit, a normal ICD analysis prior to this visit. Medication history, we have amiodarone, class 3 antiarrhythmic drug, bisoprolol, beta 1 plus NO blockade, rivaroxaban, and oral, directly acting oral anticoagulant, furosemide, a loop diuretic, ramipril, an SE inhibitor, and ivabradine, acting on funny channel current, reduces the heart rate. So the patient is breathless, paransystolic murmurs are seen, irregular rhythm, no bilateral pedal edema, lungs are clear. So there is no problem, patient is breathing. Should be breathing normally. And we echo ECG shows a wide QRS complex, confirming AF and VT. So lab investigation, hyperthyroidism, thyroid isotope, no uptake of the tracer. So it is consistent with type 2 AIT. Patient was started with IV magnesium, propyltyrosol, an antithyroid drug, which can decrease the formation of T4 to T3 mainly, and prednisolone, an anti-inflammatory corticosteroid, amiodarone, a broad-spectrum antiarrhythmic drug. Then therapy was amiodarone therapy was 200 milligrams orally once daily, continued till to control the risk of right ventricular arrhythmias. Then reverted to rate controlled atrial fibrillation from day 3 and had a successful discharge. Following 3 months of previous discharge, patient reported no symptoms of thyroid toxicosis and thyroid levels were normalized. So prednisolone was tapered, subsequently discontinued for 6 months after his thyroid damage. Why? Because prednisolone, if not discontinued, has got several side effects like we have peptic ulcer, delayed wound healing, hypertension, diabetes, and also osteoporosis. These are few of the problems apart from local toxicities, etc. So class 3, as I told you, it's a broad spectrum anti-arrhythmic drug where we see prolonged APD and QT interval, prolonged ERP also, all are prolonged. So prevents re-entry mediated arrhythmias. So once ERP is there, no further impulses can generate, even if generated, it cannot propagate. Action potential is longer, so the next impulses will go very. So I think I have told you all the things here. But you have to really remember more than the use. You have to remember side effects. It causes pulmonary 6 side effects: pulmonary fibrosis, hypothyroidism, visual corneal deposits, optic neuritis, then bradycardia, heart block to prevent, and then sometimes even QT prolongation. Dronedarone has got less of side effects, and especially hypothyroidism are very much less with dronedarone. But increases mortality and hence has got a black box warning. The other drugs are sotalol and dofetilide. Sotalol is mainly used as beta blocker, but also has got additional potassium channel blocking activity, and hence it is used for suppressing VT as a reserve drug. Dofetilide, again, there's a lot of QT prolongation and mortality increase, though it is 100% bioavailability. So these drugs, the other drugs, amiodarone has got other side effects, extra actions, but this drug do not have other actions, but should be given only by parenteral route, IV infusion, conversion from atrial flutter to fibrillation, QT prolongation, needs monitoring, needs pre-medication with magnesium for good efficacy. So as I told you, they are all They have got extra activities also, and hence they are known as broad spectrum anti-arrhythmic drugs. What are those? Voltage dependent potassium channel blocker, metabolically dependent potassium channel blocker, coronary vasodilator, membrane stabilizing activity because of sodium channels, and mainly they are used in ischemia mediated ventricular arrhythmias. Now coming to calcium channel blockers, here we have seen patient with COVID-19 pneumonia with palpitations, febrile, tachycardic, oxygen saturation 96. There is monomorphic white complex tachycardia. Sinus massage is done, and adenosine, which is given in acute cases, was really ineffective. So 150 milligrams of amiodarone slowed the heart rate, no doubt, relieved the symptoms, but rhythm was not restored. So they are diagnosed as fascicular tachycardia with a right bundle branch block. Then administered verapamil, to which terminated his arrhythmias within 1 minute, directly acting through L-type calcium channels in the myocardiac myocytes. All possible risk factors were excluded except for COVID-19 infection. On discharge, he was prescribed verapamil for a week. So class 4, L-type calcium channels from extracellular to intracellular, they are inhibited. So the cytoplasmic calcium as well as the sarcoplasmic calcium is decreased. Once they are decreased, muscle contraction will be delayed. So for that, you see that there is slow rise in the action potential and prolonged repolarization of AV node together with that increased ERP and increased PR interval, so that the conduction is totally delayed. Verapamil, the main problem is constipation and bradycardia. And because it itself causes bradycardia, do not use with beta blockers, though both are having different mechanism of action. Ultimately, they lead up into bradycardia as well as AV block. Because of this, we do not use it together. The first choice is metoprolol. If it is not subsiding, then only change to verapamil. Class 6 drugs, which is quite a question mark. Class 5 are mechanosensitive and class 6 are DAB junction, but no approved medications yet. The class 7, they are upstream target modulators. We can group it indirectly acting ACERB. Indirectly, they act and cause antiarrhythmias. Statins, the pleiotropic actions can have a mild antiarrhythmic action. Omega-3 fatty acid, there is a non-specific antiarrhythmic action. So other drugs, digoxin, as I told you, will cause arrhythmias and will also be used to treat arrhythmias. How does it cause arrhythmias? Because of sodium potassium ATPase pump, calcium entry is seen, but outward it is not seen. So calcium will have lot of calcium intracellularly as well as from sarcoplasmic reticulum, which increases the force of contraction and hence causes toxicity arrhythmias. Then how does it solve arrhythmias? The calcium digoxin has got one more action, that is vagomimetic action. It stimulates vagus and hence it will decrease the conduction from AV node to SA node and hence decreases the bombardment of impulses to ventricles and hence acts as an antiarrhythmic also. But it is third or fourth drug of choice because of its narrow margin of safety and toxic diseases, and you have to have therapeutic drug monitoring. So I think I am done with that, where I told you all these points. Now, lastly, coming to the other drugs, 46-year-old woman with the 2-hour palpitation, sign of hemodynamic instability, recurrent arrhythmias, comorbidities, ECG, supraventricular tachycardia, PSVT. Then vagal maneuvers were ineffective, and 6 milligrams of adenosine was given. So after infusion, patient had chest pain, pale skin, diaphoresis, and hypertension. Then rhythm degenerated to non-sustained polymorphic PT and spontaneously reverted sinus rhythm. Patient recovered completely within few minutes and ECG normalization. Troponin level was elevated. Angiography revealed no obstructive phenomena. So adenosine it should be given only by IV bolus. So you have to differentiate and say the reasons why some drugs are given by IV fast bolus. Some of them are given by IV slow bolus. Some of them are given by IV drip or infusion. Some of them are given by slow IV drip. So you have to know the differences between each one of them and accordingly act. So adenosine is a pure nucleoside which will and also forms a metabolite, ADPD's phosphorylation metabolite, and it suppresses AV nodal conduction and antagonizes adrenergic stimulation. Drug of choice in PSVT, which is converting to sinus rhythm, and it should be given by a quick bolus. Why? There might be plasma protein binding activity. Once plasma protein binding is there, the drug becomes inactive. So for that reason, give it as a fast bolus. The common side effects are lightheadedness, nausea, sweating, but side effects like ventricular arrhythmias, AV block, hypotension can also be seen as a delayed effect. Atropine is given whenever there is digoxin-induced PSVT. As it is anti-muscarinic, you have to be quite careful in elderly males. This will act as a vagolytic M2 blockade, vagolytic, and hence we use it in heart block, sinus bradycardia, AV block, and also induced by digoxin. There is both tachyarrhythmia, more than tachyarrhythmias, urinary retention, dry mouth, blurred vision. Urinary retention and blurred vision are the major problems. So it is ineffective in heart transplant hospital. Why it is contraindicated? Because vagal innervation is not there. It lacks vagal innervation. So vagomimetic effect is not there, especially in COVID-19 patients, and hence we don't use it. But still, whenever there is bradycardia, we use atropine IV or nowadays even glycopyrrolate to increase the heart rate. Isoproterenol is mainly used whenever we see symptomatic sinus bradycardia, which is mainly due to sympathomimetics. It is a non-selective beta-1, beta-2 agonist. Patient, when given during asthma, they say that there is relief, bronchodilation is seen, but my heart is in my hand. It is thumping. So this is the reaction what we see. And here, because of torsades de pointes or even symptomatic bradycardia, we can use this isoprenaline given IV, which can act on beta-1 and beta-2 agonists. But the problem is hypotension. We have to be very careful with these drugs. Class 1D, the ranolazine. I hope you have heard about ranolazine, which is a metabolic activator, which is used in angina. So here also we use because it reduces the late sodium current. That's the phase 1. And it affects the recovery of the action potential, refractionaries, repolarization, and also QT interval. So initially it was used in stable angina. Now it is also used in management of ventricular tachyarrhythmias. Ivabradine, as already said and done, it blocks the funny channel currents and both sodium and potassium. So hyperpolarization is activated by the gated channels and reduces automaticity. There is slowing of sinus and mainly used in heart failure or angina when the heart rate is above 100, not fully controlled by metoprolol. The last resort, magnesium, where we use it in torsades de pointes, refractory ventricular tachyarrhythmias, and also digoxin intoxication. The main adverse effects are mainly respiratory depression. So again, we have to monitor it carefully. So here I have just shown which drug can be used. They are all targeted drugs. Where can it be targeted? Either whether it's a monoclonal antibody or it blocks the TAS channels or they have an NLRP3 inflammatory inhibitors or even 5-AMP like metformin or even botulinum toxin or ARNI and also SGLT2 inhibitors where we use it in patients with diabetes and chronic heart failure. But the repurposed indications are atrial fibrillation, where the ongoing trials are also seen. This SGLT2 inhibitors, they block the sodium reabsorption and hence they cause diuresis. And also they have got pleiotropic action. So even the cardiologist can use because of the pleiotropic action, mainly decreasing the heart rate and also decreases the work of the leftover rice what we are seeing. So these are few of the drugs where we want to know the repurposed indication in many of these cases. So the newer drug, all newer drugs, doxapram, it is a task 1, potassium channel inhibition as a novel strategy. Just know the names of the drugs because you might get it as a drug of choice in MCQs. Canakinumab is a monoclonal antibody, but clinically might be significant, but statistically not significant even in randomized trial. So now we will go to some of these. I will just rush through some of these slides, which will be like a revision. Before going to this, before you are going to this, we will just solve 3 questions. I hope, I think you people should have understood. For that reason, I am asking you this. Please answer these questions. Those are online. Which of the following statement regarding use of antiarrhythmic drugs is wrong? Okay, antiarrhythmic drugs is wrong. Digoxin is drug of choice in post-MI cases of PSVT. Is it true? No, it is not true. Why? Because we are using, it causes atrial and supraventricular tachycardias and ventricular arrhythmias. So, it is not the drug of choice in PSVT because it itself can cause atrial arrhythmias. Verapamil is the drug of choice to prevent recurrences of PSVT. All calcium channel blockers acts on atria, L-type calcium channels. So, this is the drug of choice in PSVT. Verapamil is the drug of choice to terminate PSVT in asthmatic patients. Yes, because this does not act on any beta receptors, so we can use verapamil in asthmatic patients also. Lastly, lidocaine is the drug of choice in digoxin-induced ventricular arrhythmias. 100% true. So we want to choose the wrong statement. Drug of choice in post-MI case of PSVT, it is wrong. Digoxin is not the drug of choice. Metoprolol is the drug of choice. And so this digoxin itself causes atrial arrhythmias. So the second question, mark the wrong match about antiarrhythmic drug with its class. Procainamide, class 1. True? Yes. Amiodarone, class 1. Wrong. Amiodarone, class 3. Diltiazem, class 4. 100%. Esmolol, class 2. Wonderful. And it is true also. Next question. All of the following are the adverse effects of amiodarone except. I told you 6 adverse effects. So follow that. Pulmonary fibrosis, hypothyroidism, systemic lupus erythematosus, hyperthyroidism. Which one? Anybody? If anybody is there, please answer. I just told you the adverse effects of amiodarone. So the wrong answer is systemic lupus erythematosus. Which drug produces SLE? Hydralazine. Hydralazine produces SLE, not digoxin. So just one more problem. A 60-year-old woman has a MI. Which agent should be used to prevent life-threatening arrhythmias that can occur post-myocardial infarction in the patient? So which agent should be used to prevent life-threatening arrhythmias that can occur post-MI infarction in this patient? So digoxin, lecanemab, metoprolol, and procainamide. Which one will you use? As I told you, the first heart rate lowering agent used in arrhythmias is metoprolol. Okay, this is the drug of choice, which is a wonderful drug, also decreases the mortality. So beta blockers such as metoprolol will prevent arrhythmias that occur subsequent to a myocardial infarction. So none of the other drugs has been shown to be effective in preventing the post-infarct arrhythmias. Lecanemab should be avoided because it should be avoided in patients with structural heart disease. So these are the problems. So here, these are the 4 or 5 problems. So now a rush through. We have got hardly few minutes. So we will just rush through these things. Just a minute. Okay. Again, once more, revision because we tend to forget this. See, all of you know this is an action potential. We are showing delayed after depolarization. Okay, before that. See, this is the action potential. Phase 1, initial rapid repolarization. This is resting. 1 is initial, this is 4 is resting, initial depolarization, initial rapid repolarization. This is the plateau phase, and this is rapid repolarization coming back to the original position. Then 4th is the resting, so that it can go once again. This ERP is from 0 to 2.5 or 3 effective refractory period. No amount of stimulus can generate one more action potential. That is known as effective refractory period. Now, to generate arrhythmias, we get either EAD or DAD. How do we get it? So here, when there is this action potential normally is seen, the delayed action potential comes after phase 4. After phase 4, once it has attained the resting potential, but it is not in a very normal action potential. It is giving a very hump here, and this is the delayed after depolarization. So the mechanism is that it will increase the intracellular calcium accumulation, which activates the sodium calcium exchanger. I hope you remember sodium potassium ATPase pump and sodium calcium exchanger in the cardiomyocytes. So here it acts on sodium calcium exchanger, and the influx of sodium for each extruded calcium will depolarize and cause early delayed after DAD, delayed after depolarization. Early after depolarization is mainly because of sodium channels are recovering from inactivation, and before it recovers completely, there is repolarization of the action potential, and this can occur during the plateau phase, and repetitive after repolarization can trigger an arrhythmias. So these are the ones: normal automaticity and enhanced automaticity in the SEA node. And here these are the normal action potentials. These are the this one, early after depolarization and delayed after depolarization. You see exactly after phase 2 or just in phase 3 you are seeing this, whereas here it is coming to phase 4 but reducing one more, but not in the normal way. It is triggering the activity. So these are correlating with the currents. Okay, phase 4, all these you know. So phase 4, especially in SA node, inward funny current where that evaporatin acts. Okay, phase 0, inward calcium, so verapamil. Phase 3, outward potassium. So you can use some of these class 1 action or even amiodarone. In ventricle, phase 4, they are equal, so no need, normal. Phase 0, inward sodium current, so sodium channel blocker, mainly lignocaine and class 1 drugs. Phase 1, decrease in inward sodium and efflux of potassium through potassium channels. So potassium channel blocker can be used. So phase 2, plateau, inward calcium channel blockers. Phase 3, late phase of rapid repolarization, again decrease in inward calcium current and increase in outward, so that it is going to a phase of repolarization. This is the one what we have shown about the re-entry phenomenon. This is the normal conduction, and this is the re-entry one-way block. Unidirectional block is seen, which should be reverted so that no question of arrhythmias. We are afraid of arrhythmias because it can cause thrombus, and this thrombus can go on to cerebrum to cause stroke. So these are the problems. So we have to prevent that atrial arrhythmias itself first, and also clogging of the blood to form a thrombus. So this is the re-entry circuit in the ventricles. The impulse from the SA node passes to AV node, Purkinje fibers, and then to ventricles. When there is a conduction block, that unidirectional block, there is retrograde conduction, and it may recirculate in the heart and follows the re-entry arrhythmias like this. So it can follow. Then getting away like this, it can follow in this, and hence it is a circuitous pathway. Re-entry, retrograde conduction is seen. So what are the mechanisms? How to remember? One is abnormal impulse generation and conduction. In impulse generation, altered normal automaticity, abnormal automaticity, and EAD and DAD. Whereas in impulse generation, re-entry, conduction block, whether it will be left bundle branch block or right bundle branch block according to the degrees, whereas this left BBB is quite normal as we age. So what are the types of arrhythmias? I think all of you know this: tachyarrhythmias and bradyarrhythmias. I think all these are known: supraventricular in atria, SA node, AV node, flutter when it is so much, fibrillation beyond 350, Tachycardia, there is multiple extrasystoles. In ventricles, we have tachycardia initially, pulse is bigeminous, then fibrillation, then ectopics also can be seen, which is absolutely emergency. Here, bradycardia less than 60 beats per minute, where it can lead to bundle branch block either left or even right. So, other than those four classifications, we do have other drugs which can be used like adrenaline in cardiac arrest, atropine in sinus bradycardia, isoprenaline and ephedrine in heart block, phenylephrine and noradrenaline in supraventricular tachycardias. These are all alpha. This is non-selective beta. Atropine, muscarinic antagonist, but vagolytic. Adrenaline, which will stimulate by beta 1, intracardiac in cardiac arrest. Other drugs, adenosine, supraventricular tachycardia, emergency, digoxin to terminate the fibrillation and decrease the bombardment of impulses to the ventricles. Okay, calcium chloride in ventricular tachycardia due to hyperkalemia. An antagonist to potassium is calcium. Magnesium chloride in digoxin toxicity as well as ventricular fibrillation. And potassium chloride in digoxin toxicity, especially in pulsus bigeminus and ventricular tachycardias. So the same thing, reinforcement in all these cases. Okay. So bradyarrhythmias and these things you should be by hearting. See, at atrial ectopics, no drug, only assurance it will bring back to normal. This is the only thing. That's why I wanted to put this. And when there's complete heart block, artificial pacemaker, vasovagal, atropine. If it is sympathomimetic, isoprenaline. So these questions are asked because heart block you would have seen even in Hindi films, injection atropine. So we will commonly say of atropine, but isoprenaline nobody remembers. So it is a non-selective beta 1, beta 2 stimulant, beta 1 on the heart, beta 2 on the bronchus. So when we give it in asthma, patient comes back and says that his heart is thumping. Whereas when you give it in the bradycardia, it has got a very wonderful maintenance drug. So if it is complete artificial pacemaker. In esmolol only by IV bolus. Okay, only to reduce the ventricular rate. And here in ectopics, again with bradycardia, we see atropine, normal heart rate, lignocaine. And tachycardia as well as fibrillation, most often nowadays, it is cardioversion. We do not use drugs at all. So non-pharmacological treatment should be used wherever we happen to see. We should be long-term therapy should not be advocated except if there is a mortality. Most of the times we use amiodarone because it is a broad spectrum drug, and in Tosedi Potes we prefer beta blockers, and in PSVT the first four heart rate lowering drugs: beta blockers, calcium channel blockers, digoxin, and lastly ivabradine. Okay, ivabradine. So this is also one of the things with cause and treatment. Cause, if sympathetic tone is increased, beta blockers. Okay, then flutter, the cause is this, cardioversion and beta blockers most often. Okay, digoxin is reserved. Okay, amiodarone both in atrial and ventricle. Ivabradine only when it is resistant to metoprolol, not decreasing the heart rate. So these are the atrial ones, and here are the ventricle. In ventricle, most often we resort to cardioversion nowadays than of the drugs. Phenytoin is the second choice. Most often it is lignocaine because of its cardiac depressant and CNS toxicity. We try to use phenytoin, but we have to be careful. In normal doses, also it produces adverse effects, and in increased dose, it produces cerebellar ataxia also. So we have to be very careful about these drugs. As I told you, if it is vasovagal attack and increased intracranial pressure, atropine, whereas if it is due to hyperkalemia or even sympathetic, then we have to use most often isoprenaline. In AV blocks, it is mainly atropine, and if it is sympathomimetic, sympathetic blocker, it is isoprenaline. So this is once more reinforcement of sodium and sodium channel blocker, calcium channel blocker, beta adenine receptor blocker, and potassium channel blockers. So this is the type of by-hearting session of the summary of the anti-arrhythmic drugs, where we see according to their mechanism of action. So now coming to the important note. Drugs which prolong QTC interval and may cause torsity pontis. Amongst the lot, please remember antihistaminics because we are using day in and day out. And terfenadine has already known to cause QT prolongation. So a metabolite of this astimazole is the one which is used very commonly. Astimazole is the one which is commonly used. Terfenadine is banned in India. Okay, so then these sparfloxacin, the later quinolones, sparfloxacin, moxifloxacin, getifloxacin are the last generation, latest fluoroquinolones. They are also known to produce. All these are the ones which we are using very, very commonly. Amitriptyline in lower doses for diabetic neuropathy. Ciprasidone, aripiprazole as antipsychotics day in and day out, left and right. Amitriptyline mainly for diabetic neuropathy. These are specialty drugs for especially cardiac consultants and only for refilling of the prescription. This is we are using right from MBBS. We are using all these things, even including this fluoroquinolones. Antitubercular bedaquiline, which is the latest drug in antitubercular therapy. Anti-malarial. Normally, these are not used very commonly except artemisinin. ACT is the common one where we use, and oriconazole definitely we use for herpes zoster compared to acyclovir. Sorry, not acyclovir. Oriconazole is used instead of fluconazole because we can get good actions within about 5 days. Cisapride, mosapride are all banned drugs now because of QT prolongation prokinetic. We either use metoprolol or domperidone, or we use I, the cisapride, mosapride, and one more drug is there. Those are the ones which are very commonly used. We do not use cisapride and mosapride. So commonly used antiarrhythmic drugs or adenosine, amiodarone, lignocaine, both mainly IV, amiodarone orally also. Beta blockers, esmolol, sotalol, propranolol. I want you people to say that why propranolol, being a non-selective beta blocker, is the first drug of choice in as an antiarrhythmic. Please find out this and put it in the box. Lastly, verapamil and diltiazem because they act mainly on the cardiac myocytes, L-type cardiac myocytes. Amiodarone is a thyroid hormone analog, blocks potassium channels, blocks sodium and potassium, sodium, calcium, and beta receptors, hence prolonging APD, ERP, repolarization, depresses AV. So all over the heart, it is wandering. So this is the drug of choice in most of the cases. But be aware of the dogs. Like that, be aware of 6 adverse effects of amiodarone. Adenosine, it blocks, binds to adenosine receptors, opens up potassium channels, efflux, hyperpolarization, depresses AV conduction, and suppresses the automaticity, and hence terminates atrial PSVT, paroxysmal supraventricular tachycardia. This is all in all. I have shown the type of arrhythmias and the class of drugs which are used. Just tell you, I'll just read for ventricular tachycardias, which is quite an emergency, and metoprolol. These are the two very important things. In ventricular tachycardias, we normally use cardioverter defibrillator, which are commonly used to terminate ventricular arrhythmias. And metoprolol, as I told you, is the first drug of choice. Conduction is flowed through AV node with metoprolol, verapamil, and digoxin. So, but different mechanism of actions. From metoprolol, beta-1 blockade, verapamil, L-type calcium channels in the heart, digoxin, vago, mimetic. Different. Ivabradine, funny channel current. So, you should know all of them in detail. Okay. So, all these are the ones what you have to see. And beta blockers are mainly used because they decrease heart rate and promotes conversion to sinus rhythm. Long-term oral anticoagulant therapy is used to reduce the risk of stroke that is associated with either atrial fibrillation or flutter. Nowadays, the choice is either rivaroxaban, dabigatran, apixaban. These are most often dabigatran is the one which is very commonly used. The next in choice is rivaroxaban. So these are the ones what you have to know why they are used commonly, and these are the ones which are used very, very commonly and orally also. So again here, why in sinus tachycardia, underlying causes may need treatment than sinus tachycardia. Atrial fibrillation, ventricular rate control is an important goal. So, and anticoagulation is required because of the thrombus which is formed in the atria. So we are more bothered about decreasing the bombarding of impulses to the ventricles. So which can be done by most of the drugs and adenosine also. But the drug of choice mainly is esmolol, verapamil and metoprolol. Then PSVT, we have to do it by adenosine or esmolol. Then AV block, atropine and isoprenaline. Ventricular tachycardia, in ICU, lidocaine. Ventricular fibrillation, lidocaine and amiodarone. And digoxin toxicity, magnesium chloride salts and potassium chloride solutions. So, drug interactions, I would like to say more than everything, quinidine, synchronism, then CYP2D6 inhibitor, then action with antidepressants, because most of them will be elderly. They will be taking tricyclic antidepressants also, sometimes narcotics. So metabolism is inhibited by cimetidine because the cimetidine is a CYP inhibitor, and it is increased by enzyme inducers like phenobarbital, phenytoin, and rifampicin. Together with that, if they have got tuberculosis or epilepsy, such. The next very common is interferon. It's enzymes, so increases warfarin. So first of all, narrow margin of safety and hence increases concentration of warfarin. So you have to reduce the dose. Reduce the dose of digoxin, cyclosporin, which is an immunosuppressant used in organ transplantation, alprazolam, anxiolytic antidepressant, then carbamazepine used in GTCS as first drug of choice. Nowadays, oxcarbamazepine is the one which is very commonly used, but we have to be careful. It is also an enzyme inducer. Statins, especially simvastatin, phenytoin enzyme inducer. Quinidine synchronism increases and this increases the effect of dabigatran, but that's why we do not want to use dabigatran. We prefer rivaroxaban. Dronedarone, we use this because we should not use whenever we use CYP inhibitors like ketoconazole or antifungal drugs and antibiotics like clarithromycin, but this is preferred because of decrease in hyper and hypothyroidism. The last slide, what is the clinical pharmacology? First you classify and you see in emergencies adenosine, calcium channel blockers, ventricular arrhythmias, lignocaine. In both of them, amiodarone, beta blockers, and procainamide are the drug of choice. All antiarrhythmics are arrhythmogenic drugs. Class 1A tend to prolong QT prolongation. Use of drugs for prophylaxis, never practiced because all are proarrhythmics. Amiodarone, good safety margin, broad spectrum of action. Drug interactions are common with amiodarone, more so with class 1 drugs. Adenosine should be given in central or brachial vein. And due to its short acting, 10 ml fluid should be pushed into the same vein to flush it, because otherwise there will be thrombophlebitis. And also the drug can clog there. Adenosine should never be refrigerated because its efficacy will be lost. And it should be avoided in patients of derifylin. Derifylin is a drug of choice in asthma, and also when we don't know whether it is cardiac asthma or bronchial asthma. So if there is time, I would like to take 2 more questions. Is there any time? Dr. Kishan?
Yes, madam. Yes, madam.
Can I take 1 or 2 more questions?
I think, yes, madam. If any doubts, students can ask.
Yeah.
And in YouTube also, there are only appreciations are there, but no questions as such.
Because this is quite a difficult topic.
Yes, madam. Yes, madam.
And that is the problem. Okay. The questions is, I'll tell you the question. Suppression of arrhythmias resulting from a re-entry focus is most likely to occur if the drug. So what should be the mechanism of action to prevent re-entry arrhythmias? So has vagomimetic effects on AV node, is a beta blocker, converts unidirectional block to a bidirectional block, and slows conduction through the atria. So any re-entry is an unidirectional block. So we want to convert it into a bidirectional block. So the correct answer will be converts a unidirectional block to the bidirectional block. So current theory holds that a re-entry arrhythmias is caused due to damaged heart muscle, so that conduction is slowed through the damaged areas in one direction. So a drug that prevents conduction in either direction through the damaged area interrupts the re-entry arrhythmias. So class 1 drugs such as lidocaine are capable of producing bidirectional block. So the other type of question can be which drug can have bidirectional block, that is lignocaine. The other choices do not have any direct effect on the direction of blockade of conduction through damaged areas. So only in normal, if it is structural heart disease, it does not have. Has vagomimetic actions on AV node, atropine, digoxin. Beta blocker, metoprolol on AV. Slows conduction through the atria, again, beta blocker, verapamil, digoxin, and ivabradine. Next question. This you should answer. It is only naming of the drug. A 57-year-old man is being treated for an atrial arrhythmia, PSVT. He complains of dry mouth, blurred vision. It is a male, 57-year-old. So he is little elderly. So complaints of dry mouth, blurred vision, urinary hesitancy. Which antiarrhythmic drug is most likely? Metoprolol, diazopyramide, dronedarone, and sotalol. Which one? Anybody? Anybody? Metoprolol, only beta action. Metoprolol, only beta action. So, no question of all these problems. Then, diazopyramide, yes, because it has got anticholinergic effects. And all anticholinergic effects, that is atropine, should not be used in elderly males, because adverse effects are one above, one below. Above is glaucoma, below is BPH. So diazopyramide is the answer. Sotalol has got class 2 and class 3. Class 2 and class 3 effects. Class 2 and class 3 effects. The next one, 58-year-old woman is being treated for chronic suppression of ventricular arrhythmias. After 1 week, complaints about feeling upset stomach and heartburn. Which antiarrhythmic effects are seen to cause this symptoms? That is GI symptoms. Amiodarone, digoxin, mexiletine, propranolol. Yes? It's only dyspepsia, isn't it? It's only dyspepsia. It is not nausea, vomiting, and halos. Nausea, vomiting, halos are by digoxin. Mexiletine only dyspepsia. Amiodarone again causes nausea, vomiting. Propranolol does not have too many effects because it is known to it is not known to have a good oral bioavailability because of increased hepatic blood flow. Shall I continue with one or two more? Hello.
Sure, madam, definitely.
Okay. A 78-year-old woman has newly diagnosed with atrial fibrillation, not currently having symptoms of palpitation and fatigue, which is appropriate to initiate rate controlled in an outpatient. Dronedarone, esmolol, flecainide, metoprolol. Which one? Which one? Atrial fibrillation. New atrial fibrillation, 78-year-old. Will you start or not? We have to start. Which can be given orally, mainly dronedarone and metoprolol. Of the two, we can give esmolol is by IV, ultra short acting IV. So the only option to start in an outpatient is mainly metoprolol, which is very, very safe. Next is, which is correct regarding digoxin-induced atrial fibrillation? Digoxin-induced atrial fibrillation. It is used in atrial fibrillation and it also causes atrial fibrillation. Digoxin works by blocking voltage-sensitive calcium channels. Digoxin is used for rhythm control in patients with atrial fibrillation. Digoxin increases conduction velocity through AV node. Digoxin levels of 1 to 2 nanograms are desirable for treatment with atrial fibrillation. So why? Why the last one is correct? See, it is not blocking voltage sensitive. It is increasing calcium channels and also vagomimetic activity. So when it increases calcium channels, it produces atrial arrhythmia, and because it is vagomimetic, it will stop atrial arrhythmias. So it is mainly for rate control. Then it will decrease the conduction velocity through the AV node. Why 1 to 2 nanograms? Because it has got a very narrow margin of safety. And it has to exhibit negative chronotropic effect, which is exhibited between 1 to 2 nanogram per ml. So you have to be careful because of narrow margin of safety, as well as TDM, therapeutic drug monitoring. And clinically, therapeutic drug monitoring is always by a drug holiday. Last 2-3, all of the following are adverse effects of amiodarone except. So remember all the 6. Synchronism, hypothyroidism, pulmonary fibrosis, blue skin discoloration. It is synchronism. Synchronism is for quinine. Okay. Synchronism is for quinine. Okay. Whereas all the other 3 adverse effects are seen. Hypothyroidism because it is a thyroid hormone analog, pulmonary fibrosis or alveolitis, blue skin discoloration. Which arrhythmias can be treated with lidocaine? PSVT, atrial fibrillation, ventricular flutter, ventricular tachycardias. So it is ventricular tachycardias. It has little effect on AV node and SA node because calcium, mainly calcium, no sodium. That's why it is used only for ventricular arrhythmias because it is a sodium channel blocker, inactivated state of sodium. A clinician would like to initiate a drug for rhythm control of atrial fibrillation. Which of the following coexisting conditions would allow for initiation of flecainide? Hypertension, left ventricular hypertrophy, coronary heart disease, as well as heart failure. So flecainide is known to cause hypotension. So it is known to be used in hypertension. Okay, so can increase sudden death, and in those with a history of structural heart disease, only coexisting hypertension will allow for flecainide initiation. Structural disease like LVH or even heart failure and atherosclerotic disease, we cannot use flecainide. Last one, which statement regarding dronedarone is correct? It is more effective than amiodarone. QT prolongation is not a risk. Dronedarone increases the risk of death where in permanent atrial fibrillation and symptomatic heart failure. There is no need to monitor liver function with dronedarone. Which is the correct answer? C is the correct answer. Dronedarone increases the risk of death, and that's why it has not become popular like amiodarone.